Hello and welcome. I want to thank you very much for this opportunity to present our disease and our patients to you today. My name is Emily Ventura. I am the Executive Director of the PFIC Advocacy and Resource Network. I am also a registered nurse and mom and caregiver to a 9-year-old girl with PFIC type 2. The PFIC Network is a nonprofit organization based here in the United States. We run the website pfic.org. Our mission is to improve the lives of patients and families worldwide affected by PFIC. We aim to do this through education, peer support, advocacy and awareness opportunities, and research participation. I would like to take a moment to thank our generous sponsors and supporters, Mirum Pharmaceuticals, Alvareo Pharmaceuticals, the Every Life Foundation, and the Global Genes Foundation. Before we begin, I would like to introduce you to our new patient registry. The Patient Registry is an initiative that launched this past January. Our goal in having this registry is to assist in finding a better understanding of our disease and its issues from our patients. We aim to bring the community together to learn more and identify knowledge and resource gaps. We hope to continue to work to find solutions to fill those gaps and ultimately improve the quality of life for patients and families affected by PFIC. As you can see, our reach is to patients and families worldwide of any age, any subtype, either pre or post-transplant who are affected by PFIC. I want to give a quick overview of what PFIC is and its subtypes. PFIC stands for Progressive Familial Intrahepatic Cholestasis. Progressive means tending to get worse over time. Familial is a disease within the family. Intrahepatic is a disease within the liver. And cholestasis is an impairment in bile flow. PFIC is a spectrum of disease that can affect patients in different ways. A patient-specific genetic mutation leads to a protein deficiency that ultimately causes its PFIC disease. Today, you will hear from patients who experience PFIC types 1, 2, and 3, the most common subtypes of PFIC. But it's important to understand that the common symptoms and devastations of PFIC that we will tell you today are similar to what patients experience across this spectrum. There may be a variance in the disease, additional symptoms, or varying rate of progressions due to a specific subtypes that a patient is experiencing. This table was published in 2018, but there's already been one additional genetic variant identified. Our goal in coming to you today is to describe the burden of PFIC from our perspective. We're going to discuss the impact of PFIC on our quality of life and show the urgent and unmet need for treatment options. There are many devastations of our disease. The hallmark sign of our disease is pruritus, and I'll talk about that a little bit more in depth here shortly. Our patients also experience failure to thrive and vitamin deficiencies, the fat-soluble vitamins, A, D, E, and K. These are not to be overlooked. They can be severe and difficult to manage due to malabsorption of fats. When we talk about vitamin deficiencies, we talk about the trauma that can occur to our patients, including broken bones from vitamin D deficiency or complications related to bleeding from severe vitamin K deficiency. Our patients also experience a progression toward liver failure, which leads to much uncertainty because we never really know how long that's going to be. There are potential complications post-transplant, both related to being a transplant patient in general, but also related to PFIC disease. And the impact on our lives is pretty great. Our patients take multiple medications. Usually these patients are children who have to be forced to take these medications. There's a lack of sleep, a strain on family and relationships, struggle with school, financial burden, and frequent visits to doctors, specialists, and frequent hospitalizations. This is a very basic list of current interventions that are offered to help treat PFIC. There's medical management, but nothing specific or tailored for a treatment of PFIC. There's surgical intervention that's able to be offered in some. There's clinical trials. There's actually 2 drugs in phase 3 clinical trials right now that are offering our patient community some hope. And there's liver transplant. The most devastating symptom of PFIC is pruritus. Even though there are many potential life-threatening complications related to PFIC, these complications can lead to an everyday burden, many hardships, many negative feelings, including uncertainty, anxiety, fear, and depression, not to mention the physical hardships that you will hear about in our testimonials today. However, with the proper specialists involved, the disease can be managed closely and watched. The most devastating symptom is not manageable. That's pruritus. Patients and families will do anything to find relief for themselves or the loved ones. On our registry, we asked how many patients were experiencing pruritus. 85% of those who participated reported experiences. The way that their experiences with pruritus affected their lives included lack of sleep, pain and self-mutilation, fatigue, difficulty with others not understanding the impact of pruritus on their life, inconsolable crying, difficulty grooming, difficulty eating, inability to concentrate at school, feelings of hopelessness and low self-esteem, and inability to play with friends. To give a better understanding, I want to introduce you to Santiago and Armando. Santiago is a 6-year-old boy whose brother, Armando, has PFIC. One day, Santiago drew this picture without being prompted and gave it to his mom. He said, "All the red dots are Armando's PFIC." This is Armando and his experience with itching related to PFIC.
I threw it all the way to the last stair.
Thank you again for the opportunity for us to speak with you today and show you the burden of PFIC. I would like to introduce you to Dr. Saul Karpin of Emory University, who's going to give you the clinician perspective of the burden of illness and the urgent unmet need for further treatment options. Thanks, Dr. Karpin.
Thank you, Emily, and thank you to the PFIC network. I'm going to provide a clinician's perspective in the next few minutes. It's important to note that I'm a consultant for several firms in the pediatric liver space, but I want to highlight that 2 of these firms, Albareo and Mirum, are in this particular space. I'm going to go over definitions, natural history, and the burden of illness, the current therapeutic options, and how do we address unmet needs. Important definitions. PFIC stands for progressive familial intrahepatic cholestasis. It started out with a few different genetic diseases. The genes are identified in blue. The name of the protein is identified in green. That's why there's multiple names for it. But in the interest of time and clarity, and because it's the number 1 PFIC that's genetically identified, I'm going to talk about this one, PFIC2, which is also known as BSEP deficiency. And at the bottom of this, I'm showing you a schematic of what happens if the protein encoded by ABCB11, the protein is identified as BSEP and shown in the graphic here as this gray circle, that this protein is responsible for taking bile acids, the detergents that liver cells make, and putting them into bile. And if this doesn't work well, you get an accumulation of bile acids, meaning you get an accumulation of detergents in your liver cell. And of course, it's a spectrum. If you have a mild mutation in ABCB11, you have less retention or episodic retention. But if you have more severe or even frank absence of it, you get a lot of retention of it. So PFIC2 is focusing on BSEP functional deficiency and bile acid accumulation within liver cells. So I'm not going to pay much attention on the left-hand graph, but it's a reflection of when one can stratify the different mutations into mild as BSEP1 through to severe as BSEP3, you have a different outcome. And the top graph shows that those who have more severe mutations have a much less chance of keeping their liver by the time they're 5, the red vertical line. But on the bottom one, these same people have a much greater chance of developing liver cell cancer, also known as hepatocellular cancer. So the more severe mutations on the right-hand side of this slide show you have an increased chance of liver failure and need for liver transplant, and frankly, an increased chance of liver cancer. This does not really reflect what we see on a daily basis, where the major clinical features involve profound pruritus, and retention of bile acids within liver cells makes you itch terribly. It is a cause for an indication for transplantation. But because you're retaining bile acids, you now have progressive liver damage. Again, it's different in different people. If your liver doesn't work well, you don't grow well as a child. It's a time you need to grow. And I do believe there is altered development and behaviors. Families will tell you this better than me. So what do we do about it? Well, on the left-hand side is a list of medications that have been tried. Some people say thrown at, some people use the word kitchen sink. I think it's fair. It ends up being that one of these works a little bit in some patients, and that's called rifampicin. It's an antibiotic that also revs up the liver's ability to metabolize bile acids. But none of these medications have been tested, and therefore we don't know if they work. Also, during this time, when you have PFIC2, you don't absorb fat-soluble vitamins. And one of these vitamins, vitamin K, is needed for you to clot. And some patients have had life-threatening and life-altering bleeding eventualities because of PFIC2. Since bile acid retention is a part of the disease, a procedure called a partial external biliary diversion, cartooned on the right-hand side of this, where you can just siphon off some bile into a bag through the skin via the gallbladder. And if you do reduce bile accumulation, you can see this by measuring bile acids in the blood. And on the left-hand side of that, next to the cartoon, just goes to show that if you can reduce serum bile acids to less than about 100 micromolar, you have a greater chance of success of this procedure. But frankly, at the bottom of the slide, liver transplant is the mainstay of care because we don't have effective medical therapies. And frankly, it is not a cure, as you will hear from families. Many of them are struggling with post-transplant issues that don't go away. So what are the unmet clinical needs? Frankly and quickly, is that we do need to address pruritus and figure out why they itch. You can see a picture of the pruritic scars on the right. There is progressive liver damage. We do need to know how to screen for cancer and then adjust the things with growth and development. But what about potential therapeutic targets? It's a genetic disease. Why don't we just correct the gene? Why isn't CRISPR attached to this, for example? Why don't we modify the protein, like what happens in the CF or cystic fibrosis world, where with modifiers and a lot of other care, they've changed the life expectancy of those patients from about 18 to mid to late 40s. But frankly, if the root cause of disease is retention of bile acids, why don't we reduce bile acid damage? And at the moment, the best approach seems to be with IBAT inhibitors, but there are certainly other approaches as well. So the take-home points are, these are genetic diseases. We know the genes. The second point is that gene sequencing is an essential cornerstone of diagnosis. Pruritus and progression of liver disease are, frankly, a real daily, unremitting reality for families. This is important. They're dealing with this every day. We need to be able to intervene. There is a concern for liver cancer in this particular PFIC. We need to know how to screen. Diversions and transplantation are main treatment options, but certainly these are not cures. They fix things, and they don't necessarily fix things in everybody. Bottom line, we have no approved effective therapeutics. This is what's needed. We do await IBAT inhibitor trial results and FDA evaluations. I think that at least at the moment, when my toolbox is empty, this is a potential filling of that. And we need registries and new attention to novel molecular targets. Thank you.
My name is Tara Kearns, and I am the mother of 2 children with PFIC type 3. So our journey is a lot like other parents in that the itch is absolutely 100% the leading complaint. From a very early age, our oldest son at 6 months old was very itchy. to the point that he was breaking his own skin, had scars, bleeding, sleepless nights, and just overall a feeling of helplessness, not really knowing how to comfort my small child, to try and get to an itch that we just couldn't touch. So around the age of 6, our oldest son had a partial internal biliary diversion. The plan behind this surgical intervention was to help bypass part of the small intestines that recycles the bile. Overall, the idea is so that some of the bile would get eliminated from his body through his colon rather than being reabsorbed and filtered again and again through his liver that didn't know how to get rid of it appropriately. So we went through with this surgical intervention on our 6-year-old, and we were full of hope that this was it. We were going to improve his quality of life and help him not be itchy. So initially, that was true. His itch went from a 10 to about a 2 or a 3. So in our book, it was a win. We started to see growth. He started to sleep through the night, and we thought that our PFIC woes were behind us. Unfortunately, that was very far from the truth. After the internal diversion, our oldest son started to have pretty severe complications. His vitamin deficiencies that existed before surgery became 10 times worse. The vitamin K was so low. At one time, it became life-threatening. So you see, I have boys and they're really active and they love to play sports. And despite their rare disease, we try and let them have as many normal opportunities as we can. So my oldest son playing sports, he broke his arm in 2 places. Now, regular kids, they can go to the ER, doctors can take them in, place it under anesthesia, and then they're in a cast and they're good to go. For our son with PFIC, it became life-threatening. His vitamin K was so low that his blood was taking too long to clot. Before they took him into surgery, the specialist at our specialty clinic caught it and had him transferred to their hospital. Had that not happened, it was quite possible that our child would have bled on the table and died. So for us, allowing our child to play sports and experience the bumps and bruises of childhood became so much more complicated. With our oldest son, in 1 year, he had 3 breaks. He broke almost every limb in his body, and it was due to his severe vitamin deficiencies. Those are the parts of PFIC that we don't always hear about, but they really impact our lives just the same. So about 2 years ago now, the vitamin complications turned into C. diff overgrowth, turned into elevated enzymes, and the list goes on and on. Eventually, it became clear that our son was in need of a liver transplant. His liver had started to fail, his spleen was enlarged, his heart was working overtime, and it was time to list him. So here we were, just weeks before his 10th birthday, finding out that he was in need of a liver transplant. At that point, realizing that my child could not survive without it was really sobering. Something that had been our hope 3 years prior to that suddenly had become one of our greatest nightmares. All of the complications from the internal diversion eventually led us to liver transplant. Now, while I'm grateful every day for our donor and our donor family, and I'm so grateful to our son's team of specialists and providers, the hope that many people talk about with liver transplant, it's a little misguiding, because while it's beautiful and it's wonderful and we're so grateful, it's still incredibly hard. Transplant is not a cure. Transplant is a trade. Now we have traded PFIC for being immunosuppressed. We have traded PFIC medication for itch with immunosuppressants, more vitamins, blood thinners, and constant checkups to make sure that his donor liver continues to thrive in his body. So my point for you guys today is that I just want you to understand that right now we do not have a cure. We do not have options. And we just want people to understand that we would love a cure. We would love to have options.
Cedar's story with PFIC started when she was 4 months old. She had bruising on her back and swelling in her shoulder. It was enough to cause us concern and take her to the ER. In the ER, she was in full-blown liver failure. We had no idea why. She stayed in the hospital for a week, and after that week, she was discharged, but we still did not have an answer. About a month later, we finally received a diagnosis. The doctor came in, looked at us, and said, "Cedar has progressive familial intrahepatic cholestasis. What questions do you have?" And we just kind of stared at him. We had no idea what to ask. During that conversation, we realized that Cedar was going to be in for a really rough life. She was going to struggle with itching. That was going to be difficult, if not impossible, to manage. There were some medicines she could try, some surgeries that may help down the road, but none were actually guaranteed to give her relief. She was going to need to follow up at the hospital, which was 2 hours away from us, every 3 months to make sure that she wasn't going into liver failure, because ultimately she was going to need a liver transplant at some point in her young life, likely before she was 10 years old. We were devastated, and that was just the start of our journey. When Cedar was 15 months old, her symptoms were bad enough that we turned to the surgical options. There were 3 options, but none guaranteed relief. So the one that we picked was called a partial external biliary diversion. The surgery creates a stoma in her abdomen. It allows the bile to drain into an external drainage bag so that hopefully it'll escape her body and help her itching. And it could ultimately slow the progression of her disease. We were hopeful. But unfortunately, that surgery didn't work either. The only thing left was liver transplant, but she was considered too healthy by the transplant standards to actually get put on the list. So she lived this way for another 3 years. When she was 5 years old, her liver took a turn for the worst. Her disease was progressing and she was facing liver transplant. We had 2 unrelated living donors lined up, but this was a big struggle for us in itself. These living donors were friends of ours, and we had a really hard time asking them to put their lives at risk for our daughter's needs. We were fortunate enough that at the last minute, we didn't have to make that choice. She was listed and received a cadaver donor. We had so many doubts. We were terrified. We had no idea if the liver transplant was the right decision, if she was going to have a better quality of life after transplant, or if she was even going to survive that surgery. We didn't actually know that we made the right choice until a few weeks after her surgery. We saw a picture of her native liver, of the liver she was born with, the diseased liver. It was completely black. When we looked at that, that was the first moment that we realized how sick she really was. She would not have survived much longer with that liver in her body. The known catchphrase when facing transplant is that you will replace one disease with the other. Cedar was transplanted 3 years ago, and in those 3 years, she's had 5 episodes of rejection. The most recent was last week. Cedar has a rare and severe form of PFIC2. Her body completely lacked the BSEP protein, which caused her disease. Because of this, post-transplant, Cedar has been diagnosed with what is called alloimmune BSEP deficiency. It's basically a reoccurrence of PFIC disease post-liver transplant and all that comes with it, including itching, jaundice, and the possible need for further treatment. She needs to be heavily and consistently immune suppressed. Every time the doctors try to wean down her immune suppression, she goes into another form of rejection. This is really challenging for her because she's 9 years old and she wants to live a healthy, normal kid life. She wants to go to school. She wants to play at the playground. She wants to play with other kids, without a mask on. The disease has also taken a rather large toll on our family. Our family has suffered divorce, loss of job, struggle with medical bills. The types of milestones that we celebrate are how long Cedar can stay out of the hospital, which in her entire 9 years has only been a full year, 1 year. We also celebrate how many pills she can swallow at one time, which is 5. It's pretty great for a 9-year-old. Post-transplant life is still better than pre-transplant life, but for our daughter, for our family, the uncertainty is still very much there. For us, that ticking time bomb feeling never goes away.
My name is Sharon. I'm a high school science educator, a health promotion specialist, and mom to a daughter with PFIC 1. Tala was born overseas and received her genetic diagnosis of PFIC 1 when she was 9 months old. However, as parents, we knew something was wrong since 6 weeks old and fought with doctors to take our concerns seriously. PFIC is a disease that has cost my family everything. The PFIC diagnosis caused upheaval in our lives. We lost our careers, our home, our friends and family. We had extraordinary expenses of an unplanned international move, of lawyers' fees and immigration fees while we established residency for my husband, and out-of-pocket medical expenses. It also caused a significant strain on our relationships and almost a complete loss of sense of self. The PFIC 1 disease has had a devastating impact on my daughter's body and quality of life. From birth until her partial external biliary diversion surgery at 15 months, she didn't sleep, which meant I didn't sleep. She was up all night crying and bleeding and scratching. The pruritus was uncontrollable, and it wasn't until the PEBD surgery at 15 months that we were able to uncover her hands out of mittens. The ostomy worked well for us for a few years and actually gave us a false sense of normalcy. Tala was sleeping and started preschool. Brett returned to work, and I continued working on my master's. Unfortunately, an ear infection in January of 2020 caused upheaval in Tala's body once again. The ostomy stopped working and the pruritus returned. In January 19th, 2020, I started sleeping on Tala's bedroom floor. And little did I know, I wouldn't sleep in a bed again until September 4th. I was there to comfort her in the night and help scratch her body. When the pruritus returned, we had hope that we could enroll in a clinical trial. We did all of the blood work, the ultrasounds, all of the online diaries, and found out that we qualified. On the day we went to pick up the medicine, my daughter's labs showed high liver function numbers. Her hepatologist did not think it was ethical for her to proceed with the clinical trial, considering her liver showed deteriorating function. We had our hope shattered, our options taken away from us. And we learned at this point that when you fail out of a drug trial, you can no longer participate in any other clinical trials. A few months later, Tala was transplanted in July of 2020, in the middle of a pandemic. Transplant is not a cure for PFIC 1 children. We knew that the extrahepatic disease manifestations wouldn't be cured by this transplant, and my daughter would continue to have intestinal problems. However, we did not anticipate the number of post-transplant complications we would be faced with. We were told that the chances were rare, there was a low probability it wouldn't happen to us. But we've actually experienced almost every single one of them. In addition to the invasive procedures my daughter has had to continue to have since transplant, we've also had to deal with oncology consults. Tala's intestinal symptoms have gotten worse, and her nutritional status is worse than before, which I didn't even think was possible. Our families lived in a Ronald McDonald house for 4 out of the last 7 months, on and off. As hard as it was to have our lives uprooted, and as difficult as it was to watch our daughter in pain and suffer, and as hopeless as we felt when we were out of options, nothing is worse than knowing that there is no proper medicine, treatment, or cure for PFIC. PFIC, it doesn't have a cure. Transplant is not a cure. My daughter will live with PFIC-1 disease manifestations for the rest of her life. The doctors just don't have the answers. As a parent and an advocate for my daughter, there has to be more research, more knowledge translation, and more compassion in our healthcare providers. Surgical intervention cannot be the only option. I question my decisions as a medical decision maker for my daughter every single day. Did I make the right decision to transplant? Should we have waited? What could I do differently? It's a horrific burden for caregivers to feel helpless and guilty every single day. Thank you.
Hi, my name is Charmaine Gravener. I have 2 children with PFIC type 2. Tyler is age 16, Charmaine's age 12. Our story starts off the same as several of the others that you heard. The children weren't clotting, they weren't absorbing their vitamins, they had the horrifying head-to-toe itching, nobody in the house was sleeping. Quality life was just horrendous, to be perfectly honest. We are a different story in the fact that we opted not to surgically intervene with the children's condition when they were young. Data had shown that the surgical interventions weren't as effective as we wanted them to be, and our doctors were concerned that diverting would develop scar tissue that would make the transplants harder, and that ultimately we would end up with a transplant. Around the time that Charmaine was 3, we listed both children for transplant. Our perfect match hadn't come up. Several years later, in October of 2014, when Tyler, now 10, and Charmaine, 6, were enrolled in the drug trials. For us, it was our miracle drug. We went in with liver numbers that were all elevated, bile salts that were off the charts. And by December of 2014, everything had regulated. All their numbers came down. By January of 2015, the children were no longer itching. They weren't covered in scabs. Their body was healing. We were incredibly fortunate to have this miracle come into our lives. And to this day, my daughter is still in the drug trial 6 years later. My son, unfortunately, had a relapse of all symptoms last August, just shy of his 6 years in the trial. He has the head to toe itching again. He's no longer sleeping. He is covered in scabs. We are dealing with numbers that were so high, his liver numbers were so high, almost 30 times the normal level, that we breached the safety protocols of the trial, and Tyler had to stop the trial medication temporarily. The itching is just god-awful. He can't concentrate in school. He has a hard time even staying awake because of all the medication that we have him back on to combat the itching. And it is heartbreaking to watch your 16-year-old child go from feeling perfectly healthy and then asking why this is happening to him and why is he the one that's going to be the example for everybody else, because right now he is the data. I don't have answers for that, but what I do know is that more research is needed and the development of these drugs is necessary to help our kids live their best lives. And so many of these kids are listed for transplant just for quality of life, because there is no quality of life when your entire body itches from head to toe. because of bile traveling in your bloodstream. We've seen the other side of it. Thank God my daughter's still living it. But I chose to speak to you today to implore you to please consider these medications and consider the alternatives and funding the research for our kids and for the PFIC community. Because as a whole, we need help, and our children shouldn't have to suffer like this when there are other options outside of surgery. I thank you for all you're doing to help us move this cause forward.